Assalamu alaikum. Good morning. Today we'll be talking about pericardial diseases, and as usual, we'll first describe the case scenario, and then we'll have some discussion on it, and then we'll move on to the presentation and workup of these patients. So this is a case history of a 15-year-old boy who presents in the emergency room. He has fever with the flu-like symptoms for the last 1 week. He's also been complaining of sharp central chest pain, which worsens with deep inspiration and relieves a bit on leaning forward. This pain has been going on for last 3 days, but last night she had started feeling difficulty in breathing as well. So he's breathless. So the differential diagnosis we need to discuss based on this history alone. Now, this is an acute presentation with the febrile illness with some symptoms which are likely to be of viral or bacterial origin. The symptoms may be because of the respiratory involvement. The pain has some pleuritic characteristic to it, which is worsening on inspiration and probably relieved a bit on holding the breath. Now, the central chest pain, when well localized, you also have to take into account the other structures like pericardium or heart or myocardium into consideration as well. But having this young boy with the acute presentation, it would more likely be inflammation or infection of the respiratory system or a pleuritic pain because of pleuritis or consolidation or pneumonia. These mnemonic processes, they themselves can involve the adjacent pericardium and can be reason for a pericardial nature or origin of the pain. And sometimes the illness may primarily be affecting the pericardium or pericardial surfaces, and this inflammation may be there. So we have to move on to some further characteristics of this, say, illness along with the physical finding, which may help us in differentiating it, that whether it is primarily respiratory or primarily a cardiac origin symptomatology. Now this boy was sitting in the bed but visibly dyspneic. His was febrile with a temperature of 100 degree Fahrenheit. His pulse was under 10. Pulse was low volume. The characteristic the feature was that the pulse used to become impalpable during inspiration. The pulse volume would decrease during inspiration and would be a bit higher during expiration. And similarly, when his blood pressure was recorded, his blood pressure in the recorded during expiratory phase of respiration was around 110/70, but it dropped to around 90/60 during inspiration. Now, this is a very characteristic type of finding. Then his JVP was noticed to be raised. It was about 7 centimeter at an angle of 45, but it used to become more during inspiration. Now we know that during inspiration, normally the negative intrathoracic pressure would lead on to decrease in the height of JVP column. But this gentleman was having a rise in height of the JVP column during inspiration, which was quite noticeable. Now we can question over here that, one, what is the character of the pulse called as described in this patient? There is a specific name given to this pulse, the pulse which has decrease in volume during inspiration and an increase in volume during expiration, with a drop in systolic blood pressure of around more than 10 to 15 millimeter mercury recorded during inspiration and expiration. Now this is what we call as a pulsus paradoxus. Pulsus paradoxus is nothing but just exaggeration of a normal phenomena, that in normal inspiration, the negative intrathoracic pressure, there is a decrease in venous return, increase in venous return, and this increased venous return is then responsible for an decrease in the pulse volume, right? The right-sided, say, pressure, say, decrease in intrathoracic pressure augments the right-sided flow, but prevents the left-sided flow because the blood being held in lung during inspiration because of neck intrinsic pressure. But when you have something interfering with the this negative intrinsic pressure becoming more prominent, the pulse would drop further. So normally, if you record blood pressure during an inspiration and expiration, you may have a slight decrease in systolic blood pressure during inspiration and a slight rise during expiration. The difference does not uh, say has is more than around 10 centimeter 10 millimeter of mercury. Same happens to the pulse, but in conditions like where there is an fixed intrathoracic pressure or cannot change, or where there is impediment to the inflow uh, during inspiration, this further exaggerates the this phenomena, and this is called pulsus paradoxus. The second thing was that what is this physical sign named when JVP ascends or rises during inspiration? As we said, that during inspiration you have a decrease in the height of the JVP column. But if it increases, this is called as Kussmaul's sign. Now, these are the two physical signs specifically seen in patient with the pericardial effusion, or maybe with the pericardial disease like constrictive pericarditis. On examination, his apex beat was not palpable. The heart sounds were very muffled or faint as they are coming from very distance. A scratchy, rough sound was audible all over the pericardium. It was audible both during inspiratory phase uh, and it was also both in systole as well as in diastole. His lung bases were clear. His liver was palpable with a total span of around 18 centimeter. It had mild tenderness. Pedal edema was not noticed. So, combining the acute presentation of a febrile illness, flu-like symptoms, with the pleuritic type of chest pain, which get to worse on lying and get relieved on leaning forward, point auscultating, say, a pericardial rub with the muffled heart sound and a classical paradoxical pulse and a Kussmaul sign. The diagnosis is pericardial effusion or a pericardial constriction. This is chest X-ray, and chest X-ray mostly in acute phase may be normal. If it's a large pericardial effusion, you may have, say, enlarged cardiac shadow because of the effusion, which it would have loss of the contours. As you see in this X-ray, you can identify this aortic knuckle and the pulmonary artery, the left atrium, and the left ventricle. But in a patient with pericardial effusion, it would be all like a bag-like heart with enlarged shadow if there's a significant pericardial effusion. In many of the patients, the chest X-ray may be normal in acute pericarditis, and there is an, unless, as I said, there is a pericardial effusion. In that case, you would have an enlarged cardiac cillet. You need to have around 200 cc of fluid present to make the cardiac shadow prominent or enlarged on chest X-ray. This is an ECG of the same boy who's a 15-year-old boy with sharp substernal chest pain for last 3 days. So generally, the ECG may not be very diagnostic, but in some cases there are very specific findings. At the most universal finding to look on maybe just a sinus tachycardia, as this gentleman is having a heart rate of around 100 beats per minute. But as you go on to notice on the various segments of the ECG of the QRS complex, there then you notice some peculiar finding, like you can notice there is an appearance of a slight elevation of ST segment, particularly in the lateral leads like 4, 5, 6. You can notice it over here as well. This J point is elevated, and then you can also notice some degree of a PR segment. Now, the ECG finding, as I said, may be noticeable in only 60% of the patient with acute pericardial disease, and they can be staged into early findings and late findings. The early findings in stage 1, which can be seen during hours to days of onset of the symptoms, may be diffuse ST segment elevation. Notice this ST segment elevation on this arrow, which is quite sensitive for pericardial disease, uh, and it is more noticeable in leads V5 and 6, or maybe limb lead 1 and 2. Paradoxically, there can be ST segment depression in leads 1 and AVR. There is PR segment is elevated in lead AVR, but classically the PR depression is diffuse in especially. So you would have a PR segment, notice over here, which is depressed, and it gives a false impression of an ST segment being elevated. And the main thing is that notice this ST elevation. This ST elevation is with the concavity upward, whereas in a myocardial infarction, the ST elevation is with the convexity upward. So this concave upward ST segment with PR segment, say depression, is quite characteristics of pericardial disease. As I said, in early phase, there would be an ST elevation with the concave upward ST segment and a PR depression, and then this would normalize within days to weeks to have maybe settle down back to isoelectric ST segment and isoelectric PR. But sometime later, about few weeks or maybe a week or two later, there would be a diffuse T wave inversion, and ST segment would become isoelectric. And in stage 4, the EKG may normalize altogether, or there may be a T wave inversion which sometime may persist even indefinitely. As already pointed out, to differentiate between an ST segment elevation as a result of myocardial infarction or acute ST elevation or a STEMI and pericardial disease, you have to notice that in pericarditis, the ST segment starts at around the J point. It hardly ever exceeds more than 5 millimeter, whereas in myocardial infarction can be quite high. It retains its normal concavity, as you can see over here, and it is usually does not have a very characteristic localizing value as you have ST segment elevation in 1 AVL, V5-6 in say lateral wall infarct, V1, V2, 3 in anterior wall infarct. These changes in pericarditis are almost diffuse in almost all the leads. Similarly, arrhythmias are not very commonly seen with pericarditis, which is because of non-myocardial say causes. Even myocardial infarction may have an element of pericardial involvement as a result of say adjacent pericardium being inflamed as after infarction. But in that case, there may be some arrhythmias noted. Otherwise, arrhythmias are unusual in simple pericarditis, which is mostly due to this viral illnesses or bacterial illnesses. The third most universal finding to look for, particularly when the pericardial disease is accompanied with accumulation of fluid in the pericardial cavity, which is called as pericardial effusion. In that case, the ECG becomes diffusely low voltage. By low voltage mean that none of the QRS segment exceeds 5 millimeter of height. Look at this ECG, and similarly, since the blood, this heart is like floating in the pericardial fluid, so there is an element of what is called as electrical alternance. If you notice this ECG, you can notice that each alternate QRS complex has a low voltage. So you have slightly large QRS complex followed by low, a slightly large followed by low, slightly large followed by low. Now, so this goes on, and this is alternately changing the voltage in QRS complex, which is again can be considered as one of these features suggestive of pericardial effusion. So low voltage ECG would be in effusion only. Alternance, if ever noted, would again be in patient with significantly large pericardial effusions. Something about the anatomy of the pericardium. If you know that, you must recall that the pericardium, like all other visceral layers which are wrapping the viscera, they have two components. One is the which called as which is just close adjacent to the heart, right, which is called as a visceral pericardium, and then there is an outer layer which is called as a parietal pericardium. You can notice this one is the parietal pericardium, and this one is, and there is a slight space in between these two which calls a pericardial space. Now this pericardial space normally has some fluid for lubrication, which is not more than 15 to 50 ml or cubic centimeters. The outer layer normally, as it is, there is a inner layer visceral pericardium is a serous tissue which exudes or transutes some fluid, and then the rest is taken up by the parietal pericardium. Again, you notice that this pericardium is a fibroelastic sac, two layers. This one is the visceral layer, right? Which one? This one is the parietal layer, and this is the space in between, right? The ultrafiltrate of the plasma is the basic origin of the formation of this fluid in the pericardial cavity. The pericardial diseases can be of various forms or nature. The more prominent one are the acute fibrinous pericarditis, where there is a lot of fibrin material being exudated into the pericardium. This then can lead on to more of a fluid formation, which can be leading on to pericardial effusion. And another important thing about the pericardial effusion is that it may attain such a large volume that it does not let the heart to dilate during diastole to accept the blood. So this would be leading on to tamponade or cardiac tamponade. Some people have this recurrent pericarditis. They tend to have pericarditis again and again. Mostly this may have an autoimmune etiology or an inflammatory etiology. And another important thing about the pericardial disease to be noticed is that this acute pericarditis, with particularly which is of more of a fibrinous type of material being exuded, may lead on to a very prominent fibrosis of the pericardium. So the normal elasticity or ability to expand is lost, and this would then lead on to a constrictive pericarditis, which means that this pericardium now, which is wrapped around the heart, is so tightly, say, impeding this heart that it does not let it dilate. These are the major, say, mechanism of causing disease in patients with the pericardial, say, involvement or pericardial pathologies. As we described this gentleman, 15-year-old boy, which is presented with the acute pericarditis. So how common it is? It is if you talk about, there is 0.1% of the hospitalized patient, they do have this acute pericarditis, which means one in say 1,000 patient would be having admission because of this. Now, if you cut onto the emergency admissions, 5% of patients admitted to the emergency department for non-myocardial infarction chest pain may be having pericarditis or pericardial disease as cause. The most significant finding in patients with say pericardial disease would be a pericardial effusion. And if you look at echocardiography, which would be the most say favored or most yielding diagnostic modality, then you can possibly see pericardial effusion, and you can also notice that whether this effusion is large enough to impeding the ventricles being dilated during diastole or causing tamponade. You can also notice the how much pericardium has thickened. Normal pericardial thickening is something around 2 to 5 millimeter. But if it is more than that, then we call it the pericardial thickening or pericardial. This thickening may be responsible for constriction as well. Now, this thickened pericardium would have an increased echogenicity or would be more refractile on echocardiography or sonography, and of course, sometime it would be giving multiple reflections from the left ventricle during the M mode being recorded. Now, again, this thickened pericardium, if present, can be considered as say reason for constrictive physiology. Pericardial diseases, the main significant etiology or causes can be infections. It can happen following radiation for other reasons, like someone undergoing radiation for malignancies, like from bronchogenic carcinoma, or as a result of following the treatment plan in breast cancers. Primary neoplasm themselves can involve the pericardium and can lead on to accumulation of fluid and pericardial effusion. Myocardial intrinsic diseases, they like someone has a myocardial infarction, and this infarction would be leading on to death or necrosis of the myocardial tissue. But this tissue, being the adjacent visceral pericardium, would also be involved, and there would be it is not unusual to have a very localized or small pericarditis in each myocardial infarction. It may not be very significant, but sometimes this may be very prominent and may lead on to some development of significant fluid and effusion as well. So myocardial intrinsic disease like acute myocardial infarction can also be one reason of developing pericardial effusion or pericarditis during an early phase of myocardial infarction. Trauma can involve it. More commonly, we see autoimmune disorders like SLE or rheumatoid arthritis or other, say, autoimmune disorders involving the different serosal cavity, including the pericardium. Some of the drugs can lead on to an initiation of an inflammatory response in the pericardial tissues and can lead on to, and similarly the metabolic conditions like in patient with uremia or renal failure, there may be a development of a chemical type of pericarditis and pericardial effusion, and one of the common cause of pericardial effusion patient with renal failure may be uremia. Similarly, some endocrine disorders like this myxedema or hypothyroidism may be associated with development of a significant amount of pericardial effusion or pericarditis. So in summary, it's commonly the acute pericarditis can be of viral etiology, which is the most common one. Sometimes autoreactivity following some drugs, autoimmune process, and neoplastic process are usually the more common ones for when we are thinking of acute pericarditis or acute pericardial, and not to forget, as we mentioned, a very mild or minimal type of pericardial effusion developing in almost most of the patient with myocardial infarction, which may not be very significant but may be important in some individuals. When we talk of infections as etiology, the most likely, the most common organism which involve or affect the pericardium, they are viruses. So all set of viruses like adenoviruses, cytomegaloviruses, particularly in patients with HIV, influenza, and mumps virus, they can be accompanied with or associated with development of some kind of a pericardial disease or pericardial effusion. The atypical organism like mycoplasma, similarly fungi, parasites, and you name bacteria, and it may be one of the causative factor in say bacterial origin infective pericarditis or pericardial effusion. Radiation we already mentioned. Neoplasm may be metastatic or maybe primary from the cardiac. We already mentioned about this that in early infarction you may have small effusion, and similarly following 6 or 8 weeks of infarction, you may develop an autoimmune type of a reaction from the pericardium, leading on to significant pericardial effusion, pain, fever, left shoulder pain, which is called as Dressler syndromes. Now, Dressler syndromes can also happen following cardiac surgery. When this bypass surgery, some myocarditis and even aortic dissection can lead on to say some fluid being exuded into the pericardial space. Trauma we already mentioned, heterogenic causes like perforations or post-surgical, and then about autoimmune disorders like rheumatic disorders, as we mentioned, like rheumatoid arthritis or SLE, or non-rheumatic like granulomatous disorders like Wegener's sarcoid, and not to forget about even inflammatory bowel disease can also have some pericardial involvement. We usually remember some drugs which may be responsible for SLE-like syndrome and formation of fluid: hydralazine, and antihypertensive; INH or isoniazid, and anti-tuberculous drug; procainamide, which is an antiarrhythmic; doxorubicin, which is an anti-neoplastic agent; and similarly phenytoin, which is one of the anticonvulsants. We did talk about the metabolic causes like hypothyroid, uremia, and sometimes over ovarian hyperstimulation can be causes of development of pericardial disease or pericardial effusion. How far we can confidently diagnose pericardial disease or etiology? At least it is very, very difficult. Only 60% patients may have their etiology formally established on lab investigations. Getting pericardial effusion tested for tumor markers, for polymerase chain reaction, for immunohistochemistry or fluorescence activated cells. This all may add towards diagnostic yield, but most of the time, this, as you said, the diagnostic yield is not very, very high. If you talk of echocardiography in patients with pericardial effusion or pericardial disease, you can notice this is parasternal long axis view, where your probe is over here, and from here we are, say, following this like right ventricle. This one is aorta. This is left atrium. This is the left ventricle. This is the anterior cusp of the mitral valve, posterior cusp of the mitral valve. This is the posterior wall of the myocardium, and this black space over here, this is, it is the black is the fluid in the pericardium. So this is the parietal pericardium, and this is the fluid in the posterior to the heart or behind the heart in the patient with pericardial effusion. Now, if you go on to look for short axis view, you can notice this all rounded structure is the left ventricle. These are the two papillary muscles. This is the echogenic visceral pericardium posteriorly, and this is the parietal pericardium, and this is the fluid in the pericardial space, which is more so posteriorly. So this is again another view depicting that how this pericardial effusion, and this is again a left this apical fourth chamber view, right? So again, this is the left ventricle, mitral valve, left atrium. This is the interatrial septum. This is right ventricle. But look at around this is the lateral wall, and outside this you notice this black space. You notice this black space over here. which is again pericardial effusion as seen on apical four-chamber view. So to diagnose a pericardial disease or pericarditis, you have to have at least two of the following. First is that the patient would have a chest pain. Characteristics of this pain are that it is usually sudden in onset. It is well localized to the anterior chest wall. It has a pleuritic character, which means that it is increased on inspiration and decreased on holding breath. And similarly, it is very sharp in character as opposed to the myocardial infarction or inguinal pain, which is more of a sort of a pressure and heaviness. It is not very well localized sharp pain. But pericarditis pain is very sharp. And then, as we said, it has a positional element to it that it may improve when patient leans forward in his bed, and it is worse on lying flat. The first thing to make a diagnosis of pericarditis is to have a chest pain with the described characters. Then on auscultation, you may or may not have a pericardial friction rub, which is a scratchy rubbing type of a sound found having two component mainly, and say systolic as well as a diastolic component. Almost 85% of the patients would have a pericarditis, pericardial rub being auscultated. But once there is a development of fluid, now these two pericardial surfaces, they are say torn apart, and they don't say come into friction or rub against each other during each cycle. So the pericardial rub may disappear with development of a significant amount of effusion, right? Then there may be characteristic ECG changes as we already described, and finally you have an echocardiography where you may have say significant pericardial effusion. You can notice the pericardial thickness, and you can also comment about any constriction and also presence or absence of tamponade. So if you have any two of these following four things: characteristic chest pain, auscultative finding or auscultating a friction rub, the ECG changes, or echocardiography, this all would be uh, in favor of having a pericarditis or pericardial disease. The other ancillary lab investigation which can help with like is an elevated C-reactive protein levels, which is an inflammatory marker having similar significance as ESR. Uh, Sometimes you may have some slight elevation of CPK or CPK-MB and troponin, but mostly these would be in those patients who are having coexisting, say, presence of myocardial infarction along with it. And it, as I said, it just indicates that inflammation of myocardium, which is just beneath the visceral pericardium. And this elevated CPK or MB level does not suggest that this patient would have an adverse outcome. The leukocytosis is almost always there. Now, how do you manage these patients? Particularly the management of patient with acute pericarditis or patient who has, as we said, Dressler syndrome, which is development of pericardial effusion maybe 2 or 3 weeks following a myocardial infarction. All you need is that you need to restrict activity. You use high dose of aspirin, something around 750 to 1000 milligram, maybe every 8 hourly for 1 to 2 weeks. You probably have to be careful regarding the development of or say acid peptic disease or ulcer, or you would be careful in someone who had a history of previous upper GI bleed. In that case, you may even think of switching out to something else for the pain relief and relief of inflammation. Colchicine, which is an antifibrinolytic agent, antifibrosis, in a dose of 0.5 to 0.6 milligram twice a day for about 6 months, particularly in those patients who have recurrent pericarditis. Prednisolone in a dose of around 0.25 to 0.5 milligram per kg per oral for about 4 to 6 weeks is again uh, definitely beneficial in patients with acute pericarditis. If they have recurrent pericarditis, then you probably have to resort to anti-inflammatory drugs. You also have to look for, say, immunosuppressants like azathioprine and cyclophosphamide. In this category of patients who have recurrent pericarditis, you may have to think of administering intravenous immunoglobulins. Similarly, in patient with this autoimmune category with the documented interleukin 1 say elevation, interleukin 1 receptor antagonist like anakinra may be considered, and again methotrexate, again a cytotoxic drug, uh, should be or can be considered in patient with autoimmune type of a pericarditis or pericardial effusion or a recurrent pericarditis. Then we can have, like as we described, an acute pericarditis and sometime a recurrent pericarditis. You may have a chronic pericarditis, which means that it is there for months and months together. The most common etiology of chronic pericarditis is tuberculosis. So the diagnosis of a tuberculous pericarditis again would require either aspiration of fluid, if any, pericardial fluid if you can document, or going for a pericardial biopsy, which would be usually a more invasive procedures and usually not very commonly done unless you are thinking of a surgical options. So in these cases where the pericardial effusion are augmented with documentation of AFB on gene expert on a pericardial fluid or documentation of other ancillary investigations, you probably administer them standard anti-tuberculous therapy for 6 to 9 months, and in majority of these patients they would be given steroids as well. Now the steroids are usually given for around first 1 or 2 months of anti-tuberculous therapy, and they usually lead on to uh, decrease in the subsequent fibrosis and subsequent development of constriction. Sometimes a large pericardial effusion may require aspiration, and then the risk of this chronic pericarditis, particularly of tuberculosis, development of a fibrosis and constriction, which we'll be talking in a moment. As we mentioned that many of the times a patient with metabolic disorders like chronic renal failure or uremia may also develop significant amount of effusion in their pericardium, and sometimes it may be to the tune of causing tamponade. So there, apart from aspirating the fluid, dialysis may be beneficial. Neoplastic origin, say large chronic pericardial effusion or chronic pericarditis, do have very poor prognosis, as the disease is already possibly uh, widespread or metastatic, and only therapeutic aspiration to prevent tamponade to be considered. The complications of this pericardial effusion can be that there is development of cardiac tamponade. What we mean by tamponade is that the presence of fluid in the pericardial cavity exerts so much of pressure onto the cardiac chambers that the pressure in the pericardium exceeds the pressure in the ventricles, so that the ventricle cannot be filled properly during diastole, right? And particularly this pressure is more marked onto the atria, because atria are low pressure chambers. So this pressure in the pericardium, which when puts further pressure onto the uh, atria, would lead on to less filling of the fluid, and similarly the less filling of the ventricle. So this compressive effect is best seen in phase when the intracardiac chamber pressure is lower for the during systole for atria and during diastole for the ventricles. right? So there would be the classically what we say is a diastolic collapse of the right ventricle is quite say diagnostic of labeling it that the patient is having tamponade. It also depends upon that how rapidly this fluid accumulates, and the sign and symptoms of this if tamponade can be uh, say development of tachycardia, uh, hypotension, some the elevation of jugular venous pressure, and paradoxical pulse as already described. Echocardiography can be diagnostic. The most yielding diagnostic modality for cardiac tamponade would be echocardiography. What do we look for? The 2D echocardiography look for right atrial or right ventricular collapse as already described. An M mode echocardiogram would again be more significantly taking off, describing the right atrial right ventricular collapse. Uh, when you apply the Doppler say technique onto it, you can notice that the mitral inflow can be decreasing more than 25% with each inspiration, or tricuspid inflow may be increasing by more than 40% with inspiration. Inferior vena cava diameter fails to increase with inspiration. Normally, when you take a deep breath in, the IVC slightly dilates, and you exhale, it collapses. But this failure of this IVC to dilate or increase in diameter during inspiration is again one of the feature in cardiac tamponade. These are the few images where you can look at this the heart. This is the right ventricle, left ventricle. This is the right ventricular outer surface, and this is the large fluid in the pericardial cavity. This is what we were talking about. If you take an M mode recording, this is the cut section from which is taken. This is the parietal pericardium. This is the effusion. This is right ventricle. So if you notice with this ECG, this is the systole, and this is T wave following T wave. This is the diastole. During diastole, you notice this right ventricle wall being collapsing in rather than coming out. This again depicts that the change in the velocity during inspiration and expiration. During inspiration, there is fall in the mitral inflow, right? And there is rise during expiration. Treatment of tamponade is an urgent pericardiocentesis or aspiration of the pericardial fluid. Remove small amount of fluid. Even that small amount may be sufficient to relieve the patients, because if you don't do it, your patient would be having severe hypotension, collapse, and you may lose the patient. After an initial pericardiocentesis, you may need to have a continued repeat drainage by maybe indicated, and sometimes you leave in a permanent catheter for some time, which keeps on say draining the fluid which is being formed. As I said, even a small amount can lead to a very significant improvement in patient's pressure and patient's clinical condition. And after that, you may create a surgical window through subzified approach, and sometime video assisted thoracoscopy, guided pericardiotomy or pericardiectomy, or making a window can be considered as an option. A second case is a 25-year-old female who had a 1-year history of progressive dyspnea along with abdominal distension and pedal edema. She also has low-grade fever for some time, and there is history that she was treated for pulmonary tuberculosis about 10 years ago, right, when she was in the age of 15. So this is a long history of dyspnea along with abdominal distension and pedal edema. Her pulse was 90 beats per minute, and it had a paradox of around 20 millimeter. We already had explained what paradox or paradoxical pulse means. Her JVP was 7 centimeter, and it was also showing the Kussmaul sign, or say elevation during inspiration, and had a very prominent wide descent. The heart sounds were normal, but there was an additional knocking sound heard during diastole. This is what is called the pericardial knock. Now, this is a clinical scenario of a patient who has possibly developed constriction or constrictive pericarditis. So this constrictive pericarditis, thickened fibrotic pericardium, which becomes adherent to the visceral surface of the heart and impairs or restricts the diastolic filling, and thus would lead on to chronically elevated venous pressures. And the elevation venous pressure into the onto the right side would mean that there would be an elevation of JVP, and this back pressure then would lead on to distension of the liver, and then development of ascites, and of course then development of uh, say pedal edema as well. This picture sometimes can be said to have mimicking this right heart failure, but this characteristic features of pulse and the characteristic JVP would be in favor of constriction. Tuberculosis remains the most common etiology for constrictive pericarditis. These patients may not have large amount of fluid in their say pericardial sac or cavity, but again there can be coexisting tamponade sometime when there is a combination of effusion along with constriction, and the term used as effusive constrictive pericarditis. This is a chest X-ray showing what has happened, that there is a very finely rim of calcified pericardium all around the heart. Now look at this. Now this thickened calcific pericardium would not let the heart to dilate. Uh, right. So this is say lateral view of the chest X-ray showing this. Now this is again a CT scan which shows the same, that you have this thickened pericardium with a very small rim of pericardial effusion around it, and look at the lung fields, otherwise are very clear. If you operate and open up, what you notice is that there's very thick pericardium, and there's lot of fibrinous material all around the heart, which is visible. The treatment of this constriction is to begin with a medical treatment in the form of anti-inflammatory drugs. Diuresis may benefit because there is a lot of congestion in the liver and ascites and edema, and you can use loop diuretics or thiazides or maybe aldosterone antagonist. And as I said, majority of these patients have a tuberculosis etiology, and anti-tuberculosis therapy would be beneficial. But in majority, you might have to go for a surgical option like pericardiectomy. Thank you very much for say being attentive. We'll be posting the questions, and then we'll be coming on to say so your assignment which you would have to post. Thank you.